All right, let's get started. If somebody wants to do this, you can. You don't have to. But basically, what we're looking at here is this is an important clinical scenario here. So we have a shave biopsy of something, and as we always do, we ask whether we, think it's from, what part of the body is it from? Is it inflammatory, neoplastic, some of those sort of things. We can't tell a whole lot from what part of the body it's on. There are some hair follicles here. But at low power, there's something going on in the dermis, and you see these little holes in here, these clear spaces. So whenever you see that at low magnification, it should be kind of a tip-off for one of two things. Number one is maybe just artifact, and it's not actually real. So that's something you have to know. And then the second thing would be whether it might be vascular. So whenever you see little spaces at low power, you need to rule out vascular. And as you go to higher magnification, you can see that indeed it really and truly is vascular. This is not just artifact change that we see here. Okay. And it's a superficial shave biopsy. Okay. So as I recall, this came in not too long ago, and it's really problematic in a way. And there's certain things that you should never ever take a shave biopsy of and then put a differential diagnosis on a path rec slip. For example, some kind of weird soft tissue neoplasm, or something like that. You should just never take a shave and then put that in the differential, because if your diagnosis is missed, me being a lawyer, I would say, well, why did you take that kind of a biopsy when you really thought it was a serious, gargantuan, dangerous lesion that could kill the patient? And this situation carries the same sort of gravity to it. You can see that when you look at these blood vessels, they're strikingly irregular. They vary in size and shape. They have this so-called staghorn morphology. So I don't have a picture of a stag to show you, but if you can imagine a deer or an elk horn, that's kind of what these look like. They kind of have that morphology to them. They're not jagged and slit-like we see in Kaposi sarcoma. They have this pretty characteristic large ectatic staghorn morphology. And the endothelial cells that line these staghorn spaces are very large. You can see that they're protruding into the lumen. And in some cases, they're even floating freely in the lumen. And we'll see if we can find that in some of the areas over here, like maybe here, for example. That's actually fairly characteristic. And so what this is hopefully you guys have said in your mind, it's an angiosarcoma. And you should never take a shave biopsy of a lesion and write down angiosarcoma on the pathology rec slip. And if I were testifying as an expert in a case, and the lawyer asked me, well, is that a reasonable thing to do? If you really think it's an angiosarcoma, to take a small shave biopsy of it, the answer would be no. It's below the standard of care to do that. Should never do that. And the reason is I've seen a number of angiosarcomas over the years when the shave biopsy kind of just gets down about this far that have been misdiagnosed. And we're getting more and more biopsies today that are coming in with worse and worse information. And, things like small punches that have, poorly differentiated spindle cell neoplasms that look benign, shave biopsies of things like this that get called angioma or things of that nature. And then the diagnosis is delayed, and then lawsuits erupt from it. So you should never take a shave biopsy if your differential diagnosis is angiosarcoma. You should consider just plan on taking a deep punch biopsy or an incisional biopsy, or bringing the patient in at some point and then taking a biopsy at a later time. So this is an angiosarcoma. Now, there's several different subtypes of angiosarcoma, some of the so-called well-differentiated types. And when you look kind of in an area like right here, it doesn't look so super atypical. So if you just had a sample of just something like this, you might not get an accurate diagnosis. If you look at this area over here, it almost looks like an epithelial neoplasm. It almost looks like a squamous cell carcinoma. And there is a subtype of angiosarcoma that's called an epithelioid angiosarcoma. We call it epithelioid because it means it looks like an epithelium. It looks like squamous epithelium. And I've seen the diagnosis of angiosarcoma missed as squamous cell carcinoma before also. And then there are the very poorly differentiated angiosarcomas. They're just solid, poorly differentiated lesions. They can be very spindle in morphology. They can simulate atypical fibroxanthoma or poorly differentiated squamous cell carcinoma. So whenever you're like working up one of these very poorly differentiated lesions and it doesn't stain like AFX or squamous cell or malignant melanoma, you should at least think about the possibility of angiosarcoma in that differential. So this is an example of an angiosarcoma, and I don't recall if they submitted it as angiosarcoma or not, but they certainly didn't think about it and they took a shave. I've seen other cases of angiosarcoma misdiagnosed as melanoma, rule out melanoma. We wrote that case up a few years ago. It was thought to be melanoma. They did a small shave biopsy of a kind of a dark area, and it actually had a lot of hemorrhage in it. It was more of a solid epithelioid version of the lesion, and it really looked like a melanoma. It didn't have any of these slit-like spaces. They went back and then re-excised it, thinking it was a melanoma, and then it was an obvious angiosarcoma in that situation. So just realize angiosarcoma can be a simulator of other lesions. Make sure that if you do take a biopsy that you get a deep enough specimen that you're going to at least pick up the lesion and you won't leave it in the patient and not make an accurate diagnosis. So that was an angiosarcoma in that case. Okay, so this one is a punch biopsy. And you can see at low magnification, it really doesn't look too terribly impressive. The overall shape is sort of a square. And so when we, and there's a reason for that. I mean, when we see biopsies that sort of have somewhat of a square morphology at low magnification, that's usually due to some enhanced turgor of the tissue. Normally, if you take a punch biopsy from somebody's skin and you pull it out, you've all seen that in clinic. It kind of retracts. You've got a lot of elastic tissue in your skin, and so it sort of usually kind of forms almost like a little figure eight. It kind of actually it contracts a little bit here, even if you don't squeeze it. We obviously implore you not to squeeze the biopsy because it's crush artifact, but usually there's not this square morphology. So when you see something that's square, a lot of people say, that means it's morphia or scleroderma. Well, it doesn't mean that. That's one of the things that can cause that sort of, firmness of the biopsy. But other things can cause it too. If there's an infiltrate in the dermis, especially if it's one of these interstitial, mostly infiltrates between the collagen bundles, that can kind of get an increased sort of turgor, if you will. Sometimes there can be fibrosis as opposed to sclerosis, which can give you kind of a firmness to it. So don't just instantly jump to the diagnosis of scleroderma and morphia when you see that. It's obviously reasonable to think about it, but there are a lot of other things that can cause it. So low magnification, we don't see a whole lot here. We just see this sort of square biopsy. If you go to higher magnification, we do start to see something. And it's got this classic interstitial mostly pattern that we see here. Now, some people call that the so-called busy dermis pattern. That's okay if you want to use that. I guess sort of think of it as swarms of bees just kind of swarming between the collagen bundles and the dermis. That's fine if you want to think that, as long as you have a differential diagnosis for things which kind of tend to involve the spaces between the collagen bundles instead of clustering mostly around the blood vessels. So here we've got that. And as we go to higher magnification, you can see that they've got this kind of characteristic pattern that's kind of going almost north and south and east and west. And you also see that there may be, if you look carefully, some bluish gray material between the collagen bundles. There's not really any involvement in the epidermis. It's spared. It really doesn't involve the papillary dermis to speak of. This is really mostly in the reticular dermis. And so the differential diagnosis of this would include things such as granuloma annulare, the interstitial variant of GA. Perhaps you'd also want to think about things like metastatic breast carcinoma, like a leukemia that might be spreading to the skin secondarily, nephrogenic systemic fibrosis, which can give you a lot of fibroblasts that go diffusely between them on collagen bundles. And of course, usually you wouldn't see the busy dermal morphology with morphia, but in the inflammatory stage of morphia, or so-called keloidal morphia, where you can get fibroblast plus sclerotic collagen, that can give you this pattern. And then there's this entity, which is Scleromyxedema. And basically, it's got this really nice example. This is really more characteristic of this entity when you get the so-called swirled north, south, east, and west distribution of these fibroblast and histiocytes here. And you get variable amounts of mucin. Sometimes you get lots of mucin in the so-called papular mucinosis variety, where you see a ton of mucin and then these cells kind of accompanying that. And then this variant, where it looks more kind of like the fibroblast and histiocytes with relatively little mucin. And GA can really look very similar to this. I find that GA generally will tend to give you more of a perivascular lymphocytic infiltrate. Get a little bit of that here. You usually will get at least some areas where there's some palisading. And most of the cases of interstitial GA that I have seen over the years don't really have this many cells in that. Interstitial GA is pretty subtle when you see it. So I would favor, if I just saw this blind, Scleromyxedema as opposed to interstitial GA. But from a practical perspective, I don't think they would show this to you on the board examination and expect you to tell the difference between this and that entity just cold. They would probably give you some more information about it. They might say the person had a paraprotein abnormality, or they might say if you see this biopsy, what might be the next workup, and they might evaluate the patient for circulating paraproteins, expecting you to know that this would be the differential diagnosis of that, and then go from there. But so it's a fairly difficult diagnosis to make just blind without any clinical information whatsoever. But the pattern is important to recognize. So this is a pattern that is seen in a relatively few number of diseases that we just named a few minutes ago. Might throw necrobiosis lipoidic in there a little bit. Sometimes that can give you an interstitial pattern, usually more of kind of that layer cake histology with the histiocytes. But that's definitely something you want to think about in the differential diagnosis when you see this interstitial pattern. One other thing I would throw in there would be Kaposi's sarcoma in the patch plaque stage. Okay, we'll take a look at this one. This is also a fairly recent biopsy that we just had, I think about a week or two ago. And so you see at low magnification here, once again, is it an inflammatory or neoplastic process? Well, it shows a really sparse infiltrate, certainly nothing that looks neoplastic here. If it is neoplastic, it's going to be an epidermal mostly process. So something like maybe a seborrheic keratosis, a macular SK, or something like that. But they're usually not going to take a punch biopsy out of a seborrheic keratosis. They're going to probably be looking for some sort of inflammatory process. So this is sort of the bad news, if you will, as opposed to the other case we just had a second ago, where you have a relatively limited number of things that could cause that interstitial mostly pattern. Here you've got about 30 things that can give you the sparse superficial perivascular dermatitis pattern. So how do you approach this when you see this? Because you may get this on the board. I'm not sure they'd show you something that's this nondescript and expect you just to pick it out without further information. But we always ask ourselves, first of all, what kind of cells are in the infiltrate? If it's superficial perivascular dermatitis, you can see here it's just a really sparse infiltrate with just a few lymphocytes. So, that's probably the most common pattern. Then we ask ourselves, is there any epidermal involvement? Because, we see things like psoriasis with a sparse perivascular dermatitis. We see pityriasis rubropilaris. You can get sparse infiltrate there with even some eosinophils sometimes. So some of the psoriasiform dermatitis can give you a little bit of background slight inflammation. Maybe it's an irritation or something like that causes it. So we do have a little bit of that here, but we notice we don't have a totally normal epidermis. There is some acanthosis here. It's not regular. So we always ask ourselves, if there is epidermal involvement, what kind of epidermal involvement? Is it spongiotic? Is there acantholysis? Is there ballooning degeneration? Or there one of the other epidermal reaction patterns? Is it one of the psoriasiform patterns? Is it regular, irregular? So if we were going to look at this, we say, well, yeah, it is a little bit psoriasiform. It's not perfectly normal shaped epidermal rete, and they're a little bit elongated here. They vary in size and shape. Some of them are fairly long, and others are just blunted and pretty short. Okay, so there's something going on in the epidermis here. As we go to higher magnification, we're going to look at the cornified layer. And then we want to ask ourselves, what kind of cornified layer is it? Is it basket weave cornified layer? Is it parakeratotic? Is it laminated hyperkeratosis? What's the granular cell layer look like? Is it present or absent? Is it increased? Those are all various things we look at. And so as we look at it here, we see that it is increased granular layer here. It's thickened, it's prominent. And there's also what we would call laminated hyperkeratosis. There's really no parakeratosis here. There are no nuclei in the cornified layer. It almost looks like little plates of thick keratin just stacked on top of one another, like a laminated piece of wood. And so when you see that, with just a very sparse infiltrate of just a few lymphocytes here, this doesn't really look much like an inflammatory skin disease. We would think about one of the ichthyoses in this situation. Now, the good news, I think, for you is I don't think they're going to expect you to just take a look at something like this histologically and try to tell whether this is Ichthyosis vulgaris or whether it's lamellar ichthyosis or one of those. Now, they would expect you to tell the difference between this and congenital bullous ichthyosis erythroderma or epidermolytic hyperkeratosis. So you do need to know that reaction pattern, which is completely distinct from this. But you could look at this and say, this looks like it's consistent with one of the ichthyoses here. And that could be important because they might possibly show you something like this and might show you a clinical picture and ask you some questions about maybe the genetics of one of the ichthyoses or the biochemical abnormality that's associated with ichthyosis or one of those. So I would definitely recommend knowing some of the syndromes, Conradi syndrome, some of these other syndromes, kids syndrome, et cetera, that are associated with ichthyoses histologically, because they like to ask about syndromes. I don't think they would just ask you to pick out what kind of ichthyosis this is looking at it, but they very well could expect you to recognize that this isn't just normal skin. And it's also not just, lichen simplex chronicus. I mean, this is basically, you got this laminated hyperkeratosis here. So it's a nice example. This is Ichthyosis vulgaris in this case. It does have a preserved granular cell layer, which goes along with that. But basically, the laminated hyperkeratosis is the key to the diagnosis, not pityriasis rubipylaris. In that situation, you expect to see alternating ortho and parakeratosis, both vertically and horizontally. We don't see any parakeratosis here, so that wouldn't be good here. It's obviously not psoriasis. It's obviously not epidermolytic hyperkeratosis. So that's ichthyosis, and I think in this case it was Ichthyosis vulgaris. Okay, here's another scenario that you're going to see in your clinical practice pretty frequently. It's a shaved biopsy. And again, we always ask ourselves again early on, what part of the body are we on here? So we see some, thick epithelium with not a lot of epidermal rete here. And there's minimal granular cell layer, and it's got this pallor up here in the epithelium. And there's no hair follicles here. So we should think to ourselves right away that we are probably on a mucous membrane location. So mucous membrane. And just like, if you get a biopsy taken from palm or sole, there's a type of set of diseases that tend to involve those parts of the body. If you get conditions on the mucous membrane, there's a relatively limited number of entities that involve those areas that dermatologists see in the clinic. We see roulette squamous cell, we see inflammatory cheilitis conditions, we see acantholytic disorders, sometimes we see pigmented lesions of the mucous membranes, et cetera. So, you're not going to see 1,000 diseases that you're going to be expected to recognize when it's a mucous membrane site. So as we look at this at low magnification, the epidermis is a little bit acanthotic, a little bit of parakeratosis, probably been rubbed a little bit. But the main thing that we notice is that there's some pigment here at the basal cell layer. It's hyperpigmented, it's dark. And so why do people biopsy mucous membranes? Well, patients come in and they'll have a dark lesion on their lip. And clinician says, oh my goodness, maybe this is going to be malignant melanoma. And they take a biopsy of it. They do a shave biopsy, usually like this. And how do we tell the difference between malignant melanoma and a mucosal lentigo? And it's really not that hard. Most mucosal lentigos look just like this. You get hyperpigmentation of the basal cell layer. If you look really carefully, you can see that there's some dendritic dendrites of these melanocytes that extend just above the basal cell layer, kind of about this far. They don't go all the way through the epithelium. This is confined to the basal cell layer. There's no pagetoid spread of any melanocytes. There's no striking increase in the size and thickness of the dendrites. And the dendrites that you can see, they don't really travel too much away from home. They're pretty much just barely, they're kind of scaredy cats. They don't really like to get out of their house and go far away, far afield. If it's melanoma in situ, they do tend to get way up in this area here. And they'll also start seeing some pagetoid spread, some large cells with some clefts around them. They won't be confined to the epithelium here. They're going to be present above the junction here, way up in this area. It's also not uncommon to get melanophages because these things are often irritated and whatever. So you get secondary melanophages like we see here. These are not melanocytes. These are secondary melanophages that have been, this pigment has dropped out, probably because of some sort of inflammation. But you can see all of this is confined to the dermoepidermal junction. Now this, I don't know what mucous membrane this is. It's probably the lip because there may be some sun damage here, but this looks exactly the same if you see it on the genitalia. So you biopsy the penile area, the vulvar area, shows the same exact phenomenon. Biopsy the inside of the mouth, shows the same phenomenon. If you biopsy the areola, it shows the same phenomenon. If you biopsy the nail unit, a lentigo of the nail unit, acral lentiginous lesions, those also give you this same sort of phenomenon. So the key to this diagnosis is the asymmetry. You get these cells are not symmetrical and very, they're almost like little cells that are just lining up next to one another. There's no pagetoid spread. And the dendrites, the key to that is that they're not large, fat, and they're not extending far, far above the epithelium, the base of the epithelium. Those are classic findings for just a simple lentigo of the mucous membrane. Now, there are some other items that they could put in the differential diagnosis. They could well show you this. They might put in the differential melanoma, but that gets a little bit more challenging because, you know, some early melanomas can look somewhat similar to this. So I don't think they probably put that on there, but they might put something in there like argyria, something along those lines. We often see patients that get amalgam tattoos, which is basically mercury/silver amalgam. People that used to get their teeth filled when they were kids like me, they used to use those silver fillings. And every now and then the dentist would slip and stick a little bit of it in their lamina propria, and then that silver that starts staining the elastic fibers. And you can actually see the elastic fibers with the small granules of the metallic substance on there. It's actually an in vivo tattoo, a metallic tattoo. These are not metallic structures here. This is melanin and looks completely different. It's also not hemosiderin. It's not iron. Iron is golden brown. It's refractile. If you were to take the microscope and rack the condenser down, you'd actually be able to see that this melanin was not refractile. It's not a crystal, so the light doesn't get refracted through it in the same way. So those are some things that are on the differential diagnosis. They probably wouldn't put anything that could theoretically look like this, like some sort of a drug-related hyperpigmentation, but they might put something like an exogenous pigment on there to expect you to be able to tell that from melanin here. Okay. Now the next one, this one's probably the best one down here. All right, so we've got probably a punch biopsy that maybe just punched out the entire lesion. It could be an excisional, but if it's maybe like a punch excision, where they said, well, let's just, you know, this is a pigmented lesion possibly, let's just punch out the entire thing. So you can see low magnification. There's definitely some sort of neoplastic process going on here. It's not inflammatory. Something is going on in the papillary dermis and the upper reticular dermis. And even at low power, you can see that there's some melanin in here. It's pigmented. So we start thinking, okay, pigmented lesion, melanocytic lesion. So what kind of differential do we have to deal with in that score right away? Well, obviously the most important thing is benign versus malignant. Melanoma or not malignant melanoma. Those are the two number one things that we are looking at when we're looking at a pigmented lesion. So this is probably maybe a 4 to 5 millimeter punch. It's got some normal skin at the edge of it. So this entire lesion is probably about 3 millimeters or so in size. So it's small. So we ask ourselves, is it small? Is it symmetrical? We draw a line right down the middle of it, and it almost looks like one side is a mirror image of the other. So that is very symmetrical. Is it well circumscribed? And the answer to that is yes. We can see it stops right here It doesn't trickle out far beyond that area. We can draw a line exactly right there where it stops. Look at the other side, and boom, there's the last nest over here. So this is well circumscribed. So small, symmetrical, well circumscribed, pigmented lesion, favors benign at low magnification. So the next thing we do is go to higher magnification, and we're looking for some other ancillary features to see if they're there. So we may be looking for the presence of pagetoid spread. That's often seen in melanoma, but it can be seen, first of all, melanoma doesn't have to have it, but it can be seen in other situations too. So it's just an ancillary clue. It's not a pathognomonic feature of melanoma. We ask ourselves, is the process mostly nested? Or are there zones in which single cells predominate over nests? And mostly nests here, maybe a few single cells. There's really not much pagetoid spread. Then we look at the cytology. Cells seem to be relatively small. Some of them have somewhat of a little bit of the spindle cell and some of the epithelioid morphology. It's got this cluster of these dull pink globules here, which is a helpful clue to this diagnosis. And here's some spindle cells and some epithelioid cells down here. And it's pigmented. So if we put all that together, this is a nice example of a compound type of Spitz's nevus. Spitz's nevus. Notice also there's really zero sun damage here. So it probably came from a young person, might have come from a child, and it was probably relatively heavily pigmented. So as we all know, we're all taught that if something looks dark, black, we think of the ugly duckling sign, and we say, well, we want to, maybe take a biopsy of that, especially if there's some kind of history of maybe changing or whatever. And so, black lesions tend to get biopsied. The most dangerous lesions are probably the pink lesions that people don't think are even melanocytic, and they take a curettage or shave biopsy, and those turn out to be melanotic melanomas. So I think that a lot of us think that pink is the new black today. So beware of pink pigmented quote-unquote lesions. They're often melanoma. This lesion was dark, but it's actually completely benign. So that's what you want to look for when you're assessing whether something is benign or malignant from the pigmented lesion perspective. And Spitz's nevus like this, we certainly would not. I don't personally wholesale recommend removal of all Spitz's nevi, especially in children. If they have all these features here, you don't really need to re-excise it. This one's been completely removed, so certainly you wouldn't need to go back. But if it's a shave biopsy, it's got most of it out. In a young person, I certainly wouldn't recommend removal. Even in a middle-aged individual, if it's pretty classic, you don't necessarily have to remove it. I think most clinicians do remove them today, but that's because of the medical legal fear that's sort of been associated with these, because occasionally you'll see a spitzoid malignant melanoma that gets signed out as a Spitz's nevus, and nobody wants to get into a medical legal scenario. But these lesions are benign. They're not going to, kill the patient. This wouldn't be called an atypical spitzoid melanocytic lesion. This is just a compound Spitz's nevus in a young individual. Now, the other thing that you probably need to know, I'm not going to go into all the details here, but there are a number of these Spitz's nevi that people like Boris Bastian and Pedram Garami and others have been looking at the genetics of these lesions. And there's a number of these with ALK fusions, with 11 chromosome deletions and whatnot. So I would recommend at least learning about those. BAP1 mutated nevi, where you get these very large cells, and there's a loss of BAP1 in those lesions. That if it's a germline BAP1 mutation, that can be associated with melanoma, especially ocular melanoma. But if it's a somatic mutation, it's not really associated with melanoma, but it's something that can be seen, and it can be very atypical, and the cells are usually quite large. So I would recommend at least knowing something about those, because the board does like to ask some of the newer developments of things on a few questions. So it's no reason to blow something like that. It's pretty simple. Okay. A shave biopsy once again, and look at low magnification. We say, well, this looks like some type of a neoplasm here. It's not inflammatory. And certainly, just like the last one, if we apply our criteria, it looks very benign, very well circumscribed. It's got if you ever see this ball and claw type of morphology here, like we're looking at right here, that means two things. Number one, it's 99% of the time it's benign, but the one exception to that rule is occasionally we get like a metastatic lesion that goes to in this part of the skin, and it's almost sort of like an epidermotropically metastatic malignant melanoma, the small little satellite met. Sometimes those will go and form a small little nodular aggregation in this part of the dermis, and you can get a ball and claw morphology there. So it's usually benign. That's the one exception to the rule. You'll sometimes rarely get a little small nodular met, but we don't have a met here. And you can see that at low magnification, it's got what looks like this sort of grayish pallor to it. So whenever we see that, we say, well, maybe there's going to be some mucin in there when we go to higher magnification. And it's also got, what part of the body is it on? Well, it looks like it's on volar skin. This is the normal volar skin at the side. It's got the nice lamina lucida here, markedly thickened cornified layer, some thick epidermis here. So this is acral skin. So that's helpful because this entity tends to occur in that location. As we go to higher magnification, just like we saw earlier with our Scleromyxedema, we had some spindle-shaped cells. We've got spindle cells here also. And they're present in these little fascicles. They kind of interweave. We look at higher magnification. They're completely small. They're typical in appearance. There's no mitoses. There's no pleomorphism or any kind of bizarre nature to them. There's some thickened keloidal collagen bundles, which we see that in some of these fibroblastic lesions. And so when we see a lesion that's spindle cell and it looks like a neoplasm, the three things we think about are neural, fibrohistiocytic, and then muscle, smooth muscle. And we know if we look at the individual cell, the nuclei, they tend to give you sort of characteristic morphologies. If they're smooth muscle, they tend to be kind of cigar shaped, and there's also kind of an eosinophilic cytoplasm that goes along with the muscle cytoplasm. If they're neural, they tend to be more kind of lazy, more kind of delicate. And if they're just kind of little sort of, they're not really blunt cigars, they're kind of like fusiform cells, but they're not really the lazy swimming minnows in a sea. Those are usually more likely fibroblasts. And if there's a lot of fibroblasts, they often tend to kind of form little jagged sort of zebra-like aggregations. They might kind of zigzag, go this way and then this way. And so we're seeing a little bit of that here. So we say, well, these are probably going to be fibroblasts here. And also the thing about fibroblasts, they tend to go along with mucin. Fibroblasts make mucin. And so there's a lot of mucin here. And so we say, well, these are possibly or more likely going to be fibroblasts. Now, we can see a lot of mucin in neural lesions. And so if we were concerned about that, we could stain the lesion and look for SOX10 or S100 protein, something like that, and then maybe do a CD34 to prove that they're fibroblasts. But if we see this with this fibrosis, the cells that look pretty good for fibroblasts, we probably wouldn't really do a stain in this case. So this has got, it's got a good name for it in a way, because it's first of all, it's superficial in a way. It's located very superficial in the skin. It's not a deep lesion. It's on an acral skin, so that's another nice component of the name. It's got a lot of fibroblasts in it, and it's got a lot of mucin in it. So when you kind of put all those parts together, this is named, it's called a superficial acral fibromyxoma. And this is what those lesions look like. They're usually small little lesions. If you look at it at low magnification, so that kind of almost looks like a acquired digital fibrokeratoma. So before you can really make out the mucin, it looks a little bit like that overall. But then you got a higher magnification, it's got all this mucin with these fibroblasts associated with it. So that's an example of superficial acral fibromyxoma. Now, if they were going to show you this on the board and ask you to kind of just to pick it out between some other things, they might throw on there like an angiofibroma. You might say, well, does this patient have tuberous sclerosis? Because angiofibroma is around the acral sites there and around the fingernails and whatnot. That can be associated with TS, but that almost never would give you this much mucin, and it's also got a lot more blood vessels associated with it. Those lesions usually aren't quite this big, but you would see blood vessels with fibrosis, and you do not get the mucin in that condition. They might say, basically an acquired digital fibrokeratoma. Well, that doesn't have the mucin either. So again, superficial acral fibromyxoma. So remember this lesion. You might encounter it. They might show it to you. and they might expect you to be able to recognize this and understand the difference between this and some of those other entities. Pretty unusual, pretty rare lesion. I'm not sure if they will show it to you, but at least you've seen it now. Okay. This one is a fairly good example of this entity. So here we're looking at a punch biopsy this time. And at low magnification, we're going to think it's most likely going to be an inflammatory process. Not really super inflamed. We don't see a lot of inflammation here. Maybe something going on up here, maybe something going on down here. So it's a sparse perivascular infiltrate. Hard to really tell what kind of cells there are. There may be a few lymphocytes in here, but there may be some other kind of cells in the background too. That's kind of about all we can really say at low magnification. So let's go to higher magnification to see if there's anything else going on. There's something going on in the epidermis. And as we go to further, a little higher magnification, let's take a look at that epidermis. And notice that it is totally necrotic. Okay, it's dead. Whenever you see pink discoloration of the keratinocytes in here with these dark pycnotic nuclei, that's pathognomonic of epidermal necrosis. And then you've got some overlying parakeratosis. You might even have what's called, this may be an eschar. So if you look carefully, this looks like a dead epidermis here, and then you've got some parakeratosis, and you got another dead epidermis. So this could have been a situation where the epidermis was killed, reepithelialized, and then got killed again. So there may be something going on there. And if you see something like that, one of the things we always have to ask ourselves, see a necrotic epidermis, is it from outside in? Did somebody put something on it, like a toxic chemical, and it's a severe irritant reaction that's killed the epidermis? Did they scratch it? Was it burned? Was it basically electrocuted? So those various things. Or did it come from inside out? Is it an infarct? So then you want to look and see if there might be some things that kind of give you clues to that. If we were to see this, where you've got a dead, looks like an eschar, and then a second eschar, highly unlikely to be outside in. That suggests it's more likely inside out. Usually if somebody kills their skin, unless they're just kind of doing it at a very, very frequent sort of basis like that, where it has a chance to reepithelialize, they do it again. These are both dead at the same time. So that's highly unlikely that this is an outside-in job when you see that. So let's see if we can get any other clues to why this epidermis is dying. And there's all this extravasation of erythrocytes here. And here's some vacuolar alteration. So this is a reepithelialized epithelium underneath this necrotic epidermis here. And if you start looking carefully, you can see that there's a lot of sludging of these blood vessels here. And let's take a look down deeper. And here we've got another blood vessel that's really sludged. We say, well, you know, this possibly something that's inside out. Is this possibly some sort of an infarct here that's happening because of some abnormality? And when we start looking for things like that, we start worrying about things like disseminated intravascular coagulation. I think you guys had a case that was presented last night at Grand Rounds. Calciphylaxis can do this. And sometimes when you see calciphylaxis, the amount of calcification is really subtle. You see just tiny little flecks of calcium, little teensy tiny bits like that, and the actual thrombotic blood vessels may be subtle because it may be a deeper blood vessel, and all the stuff up sort of downstream of it is what you can see. And it may be really subtle to see the blood vessels. It's kind of difficult to see in this case here. But this was an example of a patient that had calciphylaxis and basically got secondary ischemic necrosis of their skin and developed an infarct. And this is what cutaneous infarcts look like. The epidermis is dead, reepithelializes beneath it, and then sometimes can even die a second time, like in this area off to the right over here. So this is a good example of just basically epidermal necrosis and an infarct. Now you might say, well, could this possibly be erythema multiforme, or could it be toxic epidermal necrolysis? And the short answer to that is unlikely to be that, less likely to be that, because that disease occurs so quickly, it doesn't have a chance to even form parakeratosis overlying it. Usually you'll see a basket weave cornified layer overlying the dead epidermis in TN or in Stevens-Johnson or erythema multiforme. So when you see this, favors the diagnosis of ischemic necrosis and look for vascular thrombosis or dystrophic calcification or something along those lines. So that was an example of a thrombotic process. Okay. Let's take a look at this. Kind of pretty. And they took this is probably a couple of different samples put in the same bottle. This is most likely kind of a punch, and then maybe an enucleation associated with it, or maybe they tried to punch something out. And here you've got a lot of fat without any epidermis. So this may be like a completely enucleated area here. And we've got some spaces in the dermis again. We talked about spaces earlier being vascular. Well, sometimes if you get an epithelial line space, it can have a central area that's kind of clear. And so it might be a cyst. And as we go to higher magnification, sure enough, it is a cyst. And so we ask ourselves, well, how do we name cysts? Basically, we name them by the type of epithelium that lines the cyst. So if it's apocrine epithelium or eccrine epithelium, it's a hydrocystoma, apocrine hydrostoma, and eccrine hydrostoma. If it's follicular epithelium, it's either like an infundibular cyst or an isthmus catagen cyst, if it's occurring kind of in the area where the isthmus and the catagen follicles, when they kind of go into catagen, they develop that characteristic sort of glassy basal membrane zone and get a tricholimal type morphology there. Some people call those tricholimal cysts. Is it a infundibular matrical cyst or pilomatricoma? That's another name for that. Is it lined by epithelium that's got sebaceous lobules in the wall? And notice the corrugated lining here. It's thrown into folds. This might actually be a tiny bit of apocrine epithelium here. And that shouldn't necessarily surprise you, because in the embryo, the sebaceous duct and the apocrine gland, the sebaceous gland and the apocrine gland come off that mantle zone area where the stem cells are. So occasionally we'll see sebaceous and apocrine in the same adnexal neoplasm. So even though these probably aren't apocrine cells, it's possible that a couple of these really could be. But most of them have this corrugated lining. It's almost like a saw. And you could this looks like a hacksaw or something like that. And then you get the sebaceous cells in the wall. So this is a steatocystoma. And we don't know whether this steatocystoma multiplex or whether it's simplex. You've got a couple of these in the specimen, so it's probably somebody that had multiple lesions. But if you just look at the individual lesion, you can't tell them apart. And here's a nice example. Sometimes you get a little bit of cornification of this. And this is basically the sebaceous duct that is basically forming the cyst. So if you sort of a little miniaturized person and you walked into the hair follicle, you took a left turn and you went into the sebaceous duct and you put a bomb in there and blew it up and it turned into a cyst, this is what it would look like. You'd have some sebaceous cells in the wall, then you have a little corrugated lining. This does have a little bit of a cornified layer to it, and it's got this morphology that you see here. Here's a little residual mantle zone, interesting here. So this is where you've got some of these residual little hair follicle, primordial structures here in the mantle zone that formed here, in addition to the steatocystoma. So these are interesting. This is an interesting little site, this little mantle zone area. It can give rise to things like fibrofolliculoma, like trichodiscoma, trichoepithelioma, all those various little follicular adnexal structures, but it can also give sebaceous and it can also give apocrine. Usually not eccrine, but apocrine plus these other structures can be seen there. So that's steatocystoma. All right. This is another one that's very important for you. Now, unfortunately, it's a shaved biopsy, but we can still make the diagnosis. And so, well, why in the world would they shave something like this? There are either two things. Either they don't really care about what they're doing, and they don't really care about what they say to the dermatopathologist, or they could be confused. So you always want to ask yourself why they might have shaved something like this when it's an inflammatory process. Look at low magnification, and you think maybe a neoplasm because it's a shaved bias, but it's got a higher magnification. You can see that it's got a superficial perivascular dermatitis consisting mostly of lymphocytes. And then, as we said before, we look at the epidermis, and lo and behold, there's a lot of abnormality in the epidermis. Okay, remember we talked about the three main types of changes: spongiosis, acantholysis, and ballooning degeneration. So which of those three types do we have here? The cells are falling apart from one another. They're not holding on to each other anymore. Normally they grasp one another. The desmosomes hold the cells together very closely. They don't like to let things go in or let things go out through the epidermis, but here we've got the cells are falling apart and they're acantholytic. So that throws us into the family of the intraepidermal acantholytic vesicular dermatitides. So once we get there, we ask ourselves, what's the level of the acantholysis? And this is where Mother Nature doesn't always read the textbooks. So if you read the textbooks, they say, well, if it's Pemphigus vulgaris, you get the nice individual layer of tombstones at the base of the epidermis here, and you get the overlying epithelium that doesn't really have a lot of acantholysis. You kind of get the kind of a normal appearing epidermis at the top, and then the little tombstone residual cells at the bottom. That's what the textbooks say you see. But here, we look at the roof, and guess what? There's some acantholysis going up all kind of through the epidermis here. And we look over here, and there's some acantholysis that sort of almost looks like that so-called dilapidated brick wall that you're supposed to see with Hailey-Hailey disease. Okay? So we've kind of got a mixed bag. We've got to get a combination of two things. And I can tell you that whenever you see this sort of trumps this. So if you see the single layer of tombstones at the base, that's very, very commonly seen in Pemphigus vulgaris, because it's not all that uncommon to see some Hailey-Hailey-like changes in the overlying epidermis. You don't get too much of that here, but in this area over here, you do get quite a bit of it. So it just kind of goes to show you that even though you're supposed to see this, and that this is the classic pattern of what you see, these often give you mixed bags, where you see some different changes, where you get more acantholysis throughout the epithelium. Now, this is really far less likely to be superficial pemphigus, because that really and truly does give you the acantholysis just up in this area right here. So once you get down to the level of the basal cell layer and whatnot, you can pretty much throw superficial pemphigus out the window. So if they were going to show you something, first of all, they probably wouldn't show you one of these lesions that's kind of got some confounding features to it. They don't like to get controversial on a board examination. They have been sued in the past from disgruntled examinees who felt like the examination was unfair and they might have just barely missed passing. And so they're not going to show you this. They're going to show you one that's pretty classic, or they might show you, something that looks like this with some immunofluorescence. It shows the intercellular IgG binding, which you know that you would not see that in Hailey-Hailey. It's going to be negative in Hailey-Hailey. They could show you this and put in the differential diagnosis a superficial pemphigus. You shouldn't choose that, because that would never give you this pattern here. They might throw Darier's. That's also acantholytic. It's acantholytic in dyskeratosis. There's a little bit of that over here. So once again, just going to show you that in the real world, these don't read the textbook. And this actually was this was true Pemphigus vulgaris here. It was positive with immunofluorescence. The patient had circulating desmoglein antibodies. So basically, it was Pemphigus vulgaris. But this is a good example just to show you in the real world, these things aren't always as straightforward as the textbook would make you think. The other thing that you can see in Pemphigus vulgaris and superficial pemphigus is an infiltrate of lymphocytes with eosinophils. And some patients can actually get a high level of circulating eosinophilia that's pretty prominent in Pemphigus vulgaris. So just remember that also. So you're going to get this on the exam. They're going to show you, you'll probably get at least 4 to 5 questions about acantholytic intraepidermal vesicular dermatoses. Probably some basic science questions. You might get some questions about perineoplastic pemphigus. So just you may as well go ahead and expect to get that on the exam. Okay. Here we got a punch biopsy. And you can see it's a low magnification. It's got a diffuse pattern, nodular and diffuse. Okay. And this is why we like to get punch biopsies of things, because you can't assess nodular, diffuse, superficial, and deep on a shave biopsy. So this would do the patient a disservice if you took a shave of this. Now, if you saw this patient and you thought this condition was a basal cell or something, that's one thing. But if you really think it's an inflammatory process, I'd much rather get a deep punch biopsy so we can really assess this pattern. And at low magnification, you can see that basically it's got this nodular infiltrate. A lot of these cells are somewhat pale. Now, there are some lymphocytes, I would say, I'm going to bet there are going to be lymphocytes admixed within this, but a lot of them look like they're little nodular aggregations, and some of them are, I'd say most of them, I'm going to bet are going to be histiocytes. So we see that, we say, well, it's probably going to be granulomatous, and we know that there's multiple different patterns of granulomatous inflammation: sarcoidal, foreign body granuloma, suppurative granulomatous, palisaded granulomatous, tubercular granulomatous. So make sure you know the various patterns of granulomatous inflammation. And as we go to higher magnification, we see that it has a sarcoidal pattern. These are sarcoidal granulomas, small round epithelioid histiocytes predominating here. Now, what's the differential diagnosis of sarcoidal granulomatous dermatitis? It's relatively small. So the first thing we think about, obviously, is sarcoidosis. And you should always rule out sarcoidosis when you have that. You can also get in certain infections can give you sarcoidal granulomatous dermatitis. Tuberculoid Hansen's disease, not Lepromatous Hansen's disease, but tuberculoid Hansen's gives a sarcoidal granulomatous pattern. You get certain foreign body granulomatous reactions are sarcoidal in nature. Some of the metallic substances like beryllium, zirconium, those things, those give you sarcoidal granulomatous dermatitis patterns. Silica, patients that get into car wrecks and get a piece of glass in their skin, that can develop a sarcoidal granulomatous dermatitis. And then this situation. So you can see that there's this dark black or brown material, and it actually, a lot of it looks really jet black, which makes you think of carbon. But then there's this other that looks a little bit brown, a little bit small, finely granular. So maybe some of it's carbon, but maybe some of it is something other than that. But certainly this is a foreign body granulomatous reaction with a sarcoidal pattern. Now, there's one other clue that we sometimes see in foreign body reactions, because whenever we make a slide, we basically take the tissue and it's in a block that's run across a razor blade, a microtome blade, and it sometimes will tear the skin a little bit, tears the specimen. Usually it's more of a vertical tear like this, but that's another clue that you're maybe dealing with something in there that's that it can't be cut with a razor blade and just rips it through the skin. So if you see that, that's a clue that you're dealing with a foreign body. But here you can see that there's this foreign material, and this brownish, blackish material is very characteristic of the type of tattoos we see in patients that get these cosmetic microblading tattoos, when they get the tattoo of their eyebrows or their maybe their lips or the eyelashes. They often will put this sort of vegetable material that's this dark brown to sometimes blackish color, because they want it to sort of look dark. They want your eyebrows to look dark black or your eyelashes to look black. And this material is actually very antigenic. It's comprised of this vegetable dye. So it's an, quote, organic, in quote, substance, and your body has a reaction to it in a fair percentage of cases. The other thing that happens is if patients have a tendency to have sarcoidosis, this can trigger sarcoid. It actually can cause it's kind of almost like a Kebner phenomenon. But we've actually seen patients that get this microblading, and then they start getting sarcoidal granulomatous reactions, not only at the site where they get the tattoo, but also it triggers lymphadenopathy, and they can get hilar lymphadenopathy. They can get Lofgren syndrome, and they get their lacrimal glands start getting inflamed. So it actually can trigger systemic sarcoidosis in some cases, interestingly enough. So make sure you know this pattern and understand the things that can lead to that. So one last one before we stop. We've already talked a little bit about this pattern. And this is another one of these epidermal reaction patterns that you just better know and make sure that you can know the various 6 or 7 entities that cause this. So this is something that you look at this, you say superficial perivascular dermatitis, but the main change in the epidermis. And you see that at low magnification. There are these holes in it. There's abnormal cornified layer. It's focal, 2 different foci here. And as you go to higher magnification, this is like, dermatopathology board exam 101. You're going to definitely see this on the exam also. It's got the classic findings of focal acantholytic, cells aren't hugging each other anymore, dyskeratosis, focal acantholytic dyskeratosis. The most common setting is Grover's disease. And as I'm sure you guys know, there's about 6 different subtypes of Grover's, ranging from Pemphigus superficial and deep type of Pemphigus, the Haley type, the spongiotic type, and then this type, we get FAD. Now they've even added epidermolytic hyperkeratosis rarely. And then Darier's, linear Darier's, which is an epidermal nevus. Basically, you can get focal like widespread dyskeratotic comedones, which you biopsy those and it shows this familiar dyskeratotic comedones. That can look like this. So there's about 4 or 5 different entities, and you need to make sure that you know every single one of these. You've probably heard of the corones and grains. Basically, a grain is just an acantholytic dyskeratotic parakeratotic cell. The corones basically means round bodies in French. And basically, they're just round acantholytic dyskeratotic granular cells like you see right in here, and maybe little spinous cells here. So they're corones and grains. That's not specific for Darier's. That can be seen in Grover's. Any of the diseases get that. Warty dyskeratoma, that's yet another one. Solitary dyskeratotic keratosis. Multiple widespread dyskeratotic keratoses. So anything, there's about 5 or 6 different diseases. Make sure you can recognize this reaction pattern. You're going to see this on the exam also. And this is a nice, beautiful example of the histology. If this person happened to have Darier's this time, but you wouldn't really be able to tell that from Grover's necessarily. Usually Grover's is smaller than this. Usually you don't get 2 foci within the same biopsy, but nevertheless, it's a reaction pattern you need to be familiar with. So thanks again, and we will see you soon.